So, Jack, welcome. For housekeeping reasons, we would ask that you please all mute yourselves. We will have a question and answer session at the end, so please feel free to type in your questions as the presentation is conducted. And also we'll have time for you to raise your hands, and then we'll respond to your questions that way. So thank you, Jack. Over to you.
Thank you, Renee, for asking me to do this. So I'm going to focus on what we've been doing at a provincial level and what we've put in place for the health and safety in terms of the COVID pandemic. And when we look at the overarching policy that we had for this was published in Circular H58, where we highlight the policy. It's also a legal requirement in terms of a recently published, you will see on the 4th of June, the Department of Employment and Labour published some information on how workplaces should manage COVID in their settings. The previous version of this actually excluded healthcare facilities, but the one that was published on the 4th of June now includes all workplaces that also render health services. And the typical approach that one will see in all these documents is what we would refer to as the general occupational health and safety approach in terms of any workplace hazard, and then in this case, COVID specifically. And that basically is the requirement to perform risk assessments when you've identified the risk, to mitigate those risks, then do medical surveillance for the risks that still remain. And then obviously from the medical surveillance, one might detect some cases, and there's some case management that one would have to do in those cases. So I'm just going to start and show you some of the things that we've done. The first one, the risk assessments we did on a number of levels. The first one would be at a personal level for each employee to look at who are the people that are really vulnerable for getting severe COVID disease. And when we look at the literature in the beginning, there wasn't a lot of information available, so we had to publish something fairly quickly in terms of assessing people. And these were the studies that basically came from China initially, and we then developed a circular H50 that talks to the individual risk assessment for vulnerable staff. But since then, there have been a number of publications coming from Europe, from the Americas, from the UK, and there are a number of things that have developed since, and that we can see. For instance, one can look at this huge study from Pretelli et al. From the US, more than 4,000 people that were involved, looking at risk factors for hospitalization. And again, one can see the typical things that were seen in other studies. Age, by far, seemingly the more important risk factor to identify. People not with all heart problems, but specifically then heart failure. One can see that coronary artery disease and others not as important as we previously thought, but then also BMI to be a risk factor in this type of environment. So for hospitalization, if the outcome is changed to critical illness, in other words, not only anybody that was admitted to hospital, but people requiring mechanical ventilation, people that were discharged to a hospice or died, then the picture changes a little bit. Again, age seems to be an important factor to consider over here. And then BMI, again, statistically significant, those two factors. Again, quite a large study, 1,500 people that were in that study. And when one looks at the data, all of these comorbidities doesn't seem to be as important as we previously thought. And the most important risk factors seem to be related to age, and a clear trend that is shown with increasing age in many of these studies. These are ratios, hazard ratios. So when we look at the actual rates, so this is estimated case fatality rates from New York. one can see that it is still quite significant. Cardiovascular diseases estimated to be around 10%, diabetes 7%, and so forth. So it's not something that is insignificant. In our own province, recently presented some data on mortality and the hazard ratios for these. And again, we can see the same trends for age. So increasing age increases your hazard ratio. But interesting also is we had some more data available for diabetes specifically. So for diabetes, in all the other studies, it's more a binary yes, no, do you have diabetes? But with us, there's a clear trend also with the level of control. So if you've got well-controlled diabetes, your risk is less than a person that is poorly controlled or then totally uncontrolled as measured by HbA1c values. Also, we can see with tuberculosis, compared to people who haven't had tuberculosis, the risk is increased if you previously had tuberculosis or then current tuberculosis. And then HIV, the data that we currently have is just binary yes, no, and no data at the moment based that can give us information on things like viral loads or CD4 counts and so forth. That will probably come in future as we get more data available. But basically, what we've done from the occupational health point of view is to look at the information and then come up with a risk matrix to identify these individuals, people with conditions, and then obviously the vulnerability of that person, whether it's low, medium, high, or very high, and then also looking at where these people are working to determine what their overall risk would be. And when we have that, I refer to this as like a naked risk score. This is your vulnerability and the environment that you're working in, but it doesn't take into account any control measures. And this is where the occupational health system needs to start kicking in. In other words, to control these risks. Unfortunately, many people see these vulnerability assessments as identifying people who are required to go on special leave and should not be able to work. But that's not the intention. The intention is to say, even if you are vulnerable, can we reduce the risk to acceptable levels where your risk would not be higher than, for instance, when you go home and you go shopping and so forth. And then if that is the case, then one can certainly still come to work. And we have some vulnerable individuals who still present to work based on the reduction in their risk, which is the important step in the circular H50. So early on, we already gave some suggestions on how the risk can be reduced for COVID in the workplace based on engineering, administrative controls, etc., etc. And there's then an agreement between the employee and the line manager in terms of, if you are vulnerable, this is how we are going to support you. But then also, if a person has got higher risk scores, the person can be referred to the occupational health clinic to say, is there some special occupational health measures that we need to put in place for this person, and then make recommendations. And one of them obviously could be a review for special leave, and making sure that people that are highly vulnerable do not get infected and require hospitalization, especially during the time of the peak, so that we don't have employees with high vulnerability then contracting the disease and not being able to get the medical care that they may require. So that would be the personal risk assessments. We also need to assess the workplace areas, and again in the circular we address the workplace area assessments. And basically what this means is that one needs to go to a specific workplace, look at all the tasks that are performed in that area, and then assess the risk of exposure associated with these tasks. And then that will determine certain control measures that might be required, which brings us to the risk mitigation, again addressed in the same policy: engineering, admin, PPE, and influenza vaccination. but then some very specific guidelines on how to prevent and how to manage coronavirus infection in healthcare settings, Circular 877, with a lot of practical advice on what facilities should do to make sure that they protect their employees. And this range from engineering controls, administrative, etc. So, for instance, this is one of the ICUs we've got here in Tygerberg Hospital, and you can see the engineering control, the screens that we've put on between patients to make sure that spreading from one to the other is mitigated. Administrative controls, making sure that there's a workplace plan and policies in place, and that these provincial policies are then adapted and adopted, and making sure that it can be applied in the specific local setting, that there are standard operating procedures, access control at the facility, signage to show exactly where people should go should they present with symptoms, or that they don't have to walk around and contaminate many working environments simply because they don't know where to go. Taking evidence-based decisions, making occupational health and safety and IPC advice available, and then also making sure that the environmental cleaning is updated, and then all the other things, contact tracing, training, etc., etc. So in terms of the personal protective equipment, this is obviously something that was addressed fairly early on, and because it was a novel virus in the context of China, they obviously had to go for the highest level of PPE that was required. But because we now know that it is a coronavirus and how it spreads, etc., we could then provide more specific guidance in terms of the PPE that is required for specific tasks that people are required to perform. Universal face covering is something that was driven at a very high level in our province, and we were involved in the national level discussions, etc. And Dr. Engelbrecht also very early on assisted us in getting directives within the province way before all the other provinces in terms of universal face covering, and this has been accepted in the whole of the country since then. Even with the Department of Labour directives, there's a requirement that everybody should wear cloth masks, and then obviously if a person is ill, coughing, and you're a healthcare worker, surgical mask for these people. In terms of environmental cleaning, there's a requirement that this is well planned in all areas. There's enhanced cleaning required for obvious reasons. And normally when we look at the way cleaning was happening in admin areas and offices, for instance, that was done once a week. And of course, it's required that these must be enhanced and very regularly, especially the high touch surfaces. And one of the important considerations is what the decontamination is going to be like when there is a case. For instance, if a person has got a very cluttered office space with lots of surfaces that could be contaminated, this is going to be very difficult to clean and decontaminate. And therefore, an important aspect would be to ensure that all areas are decluttered and easily cleaned in case there is a case that is notified. A lot of questions have been asked about deep cleaning by fogging systems, and as we know, there's no clear evidence for this on top of the normal terminal cleaning that we do in the hospital settings in any case. But this has been driven quite a lot by contact people have with the other industries where terminal cleaning is not a concept that they do regularly. So in terms of the terminal cleaning that we do in the hospital, we know that is sufficient, and fogging systems is not an absolute requirement. But we found that it actually plays a very important psychological role, and especially staff that don't understand terminal cleaning and the role that it plays. many of them would refuse to come back to work unless a fogging system has been used. An important aspect, however, that we had to stress from the beginning is that the virus is really fragile, and people are able to return to work immediately after the decontamination has taken place. There's no need to stay out of the work for 3 days, etc. That has happened in other settings. And the question, of course, is why is it different in the hospitals than in police stations, for instance, that they would close down for 3 days? And the reason is simple, is that in police stations, they normally would do cleaning with soap and water, but they would not disinfect. And therefore, they don't have disinfection systems like we have in hospitals. And to get outside companies to come and do that, they often then need to close those workplaces, whether it's a police station or a shop or a Pick and Pay or a Checkers or whatever it is. They are required to close their operations for a while until that deep cleaning, or what we would refer to as terminal cleaning, has been completed. In terms of the survival of the virus on different surfaces, we can see that in many surfaces, on banknotes, stainless steel, plastic, etc., you can see 2 days, 4 days. There are many of these surfaces where the virus can live for quite a long time. But disinfectants, even things like household bleach, soap, ethanol, iodine, chlorhexidine, so all the things that we see in disinfectants, they are very effective and almost on contact. The only exception here is at 5 minutes, but not at 15 minutes. You can still detect some virus if you use pure soap without any disinfectant, and that's obviously understandable. But if any disinfectant is added, the virus is essentially undetectable by the time that the disinfectant is dried in the environment. So those are all the things in terms of risk mitigation, and in various settings, different aspects need to be implemented in this multimodal approach. But then still, people might present with disease. So medical surveillance is critically important. Many operations and smaller clinics, workplaces outside of the healthcare sector would do screening upon entry into the facility, which is certainly something that can work. In our setting, where our hospital has got about 5,000 employees, that is quite difficult, and we would see long lines of people standing outside. So we opted to go for a buddy screening system where people would screen with another employee every day and basically do the screening with the temperature and then the typical symptom screening in order to identify people that are symptomatic. And if cases are then identified, dealing with the cases, so symptomatic staff, people that have been exposed, and to do the exposure risk, we very early saw that it's absolutely necessary to have a very clear approach to employees with these, because people are concerned if, for instance, a colleague is diagnosed with COVID or they are working with COVID patients. So we developed this flow diagram to say who are the people that should go for COVID testing. And if they go for COVID testing and it's positive, what the actions are. If they screen negative, how they should be managed, and also people that are asymptomatic but have had a history of exposure, how they should be managed, and the daily screening for symptoms, as I alluded to earlier. But then also quite important is to identify high risk exposures. So what we don't want to see in workplaces are the high-risk exposures where people are closer than 1.5 meters for longer than 15 minutes and they don't wear PPE. These high-risk exposures, if one looks at the literature, and there's a study published about 2 or 3 weeks ago, if I remember correctly, where they looked at exposures in the home environment. So between husband and wife, children and the family and so forth. And in this type of setting where there's close contact and high risk exposure, people contracted the virus at a rate of about 10 to 13%, which is not as high as one would think, but still we don't want those type of exposures in our setting. So we then immediately said that when these happen, a workplace assessment must be performed, where the line manager then says, what are the things that went wrong? So why are people closer and longer and not wearing their PPE? And that there be plans implemented to say, how are we going to prevent this from happening in future? And for instance, one of the things that we found very early on is that the high risk is obviously where exposure to the face was happening, and that was the tea room. So people were sitting close to each other, taking off their masks, sharing cups and spoons and so forth. And that was where some of the outbreaks in our setting was happening. And it was important for us then to identify this as a risk factor, and then to make sure that this doesn't happen. And these recommendations are then formulated by somebody who specifically investigate these high-risk exposures in the workplace. And then there's some actions and a personal response, a person identified who's responsible, so that we can act as a learning organization and learn from mistakes and learn from these exposure incidents. And this is also then forwarded to the Health and Safety Committee, so that we can make sure that this is not just learned within that particular environment, but that it is actually taught throughout the hospital, and that everybody could implement this. Also, obviously, if cases are identified, there's a need to complete the compensation documentation. And the question obviously is this an occupational case, yes or no? And generally speaking, it is an occupational case if you are exposed in the workplace to a known source of COVID. So this would be all workplaces where working with COVID patients is not an inherent requirement. It's however important to notice that it's also presumed to be occupational required if the transmission of COVID is inherently prevalent in the working environment. And this will be typical of healthcare settings. And therefore, COVID-19 during this outbreak, this 3.1D in the circular from the Compensation Commissioner basically means that COVID is seen in terms of Section 66 of the COIDA Act as something that is now part of Schedule 3, and therefore it is presumed to be occupational if it happens in the healthcare setting. However, if it is proven that it happened outside of the healthcare setting, then of course that information will be forwarded as well. So if there's any doubt in healthcare workers, the legislation makes one err on the side of reporting this as an occupational disease. So this is something that our clinic has been busy with quite extensively, because there's a whole list of documents to be completed, which is the employer's report, the notice of an occupational disease, the first medical report, a copy that is sent to the Provincial Department of Labour, the progress reports. There's a specific COVID-19 exposure questionnaire that was published in the circular instruction by the Compensation Commissioner. There's the exposure history notification, the resumption report, the investigation of the incident in terms of the general administrative regulations, the lab results, the medical report, the impairment report, and then the final medical report. For some, if there's a death, obviously there's the WCL 32, 46, 30, 305, 29. You may reopen a claim if there's some conditions that requires further treatment for a case, and those would be only in severe cases, obviously WCL 20 and 69 for some of these. So quite a lot of documents to be completed on the compensation side, and long consultations in our clinic with employees who return to work. Also, to make sure that we are able to provide all these services across the province, our provincial management have also allocated the services of, or the support of a registrar and a specialist to each of the substructures and the districts and so forth. So each of them will have a registrar and a specialist assigned, and they can obviously phone us for advice and support in these things. So quite a lot that one needs to put in place, and our experience is that having a single approach is not effective. You must have a multimodal approach, and making sure that all of these requirements are met in order to reduce the risk, and making sure that the staff are safe. To bring it all together and making sure that this is filtered down to the work phase, the coal phase level, we also developed a checklist for line managers to make sure that these things are implemented. We gave them the specific references, so which pages in the document they need to do, and which evidence is required to know that these things are in place. From the vulnerability assessments that have been done, as I've said, the area risk assessment, that risk mitigation strategies are implemented, that they have a PPE plan in accordance with the guidelines. But those PPE plans we also submitted to myself at the UIPC for approval to make sure that it's in line with the provincial guidelines. Wearing of face covers, environmental cleaning must be updated and planned specifically, that symptom screening is done by all staff for the medical surveillance, that everybody has been informed on how to manage a case if there's exposure or if they have symptoms, etc. So the whole flow diagram that they can use. There's training that was booked, and we've got a training register. At the moment, we're going through our third round of training all 5,000 of our staff members. So we've already gone through everybody twice. We're going through our third round at the moment, and then a system in place to ensure access to occupational health and support. So for people who don't have an occupational health clinic in place, the support, as I said earlier, from a registrar and a specialist within the province, and then also not to forget the psychosocial support systems that is available, Circular H92, and we've got a resiliency clinic in our hospital with support from the psychologist and psychiatry departments within the hospital. So this is the whole system that we've implemented, and I thought that I would just run through this very quickly, because oftentimes there are a number of questions around this in terms of the practicalities and some of the details, and I'd rather spend some time on some of these specifics rather than carrying on with a long presentation in this regard. So I think I'm going to stop there for now, and then we can have a little bit of a discussion around this.
Thanks, Jack. That was really excellent, and it's really great to see a presentation that brings a lot of the practicalities as well as the theory of occupational health and medicine together. I see I have a hand. Hassan, would you like to ask your question? And I'd also just like to encourage everybody to please mute yourselves. If you have a question, you can either type it out or raise your hands. Thanks, Hassan, over to you.
Thanks, Jack. Great presentation. Thanks very much. And clearly we've learned a lot over this COVID-19 period and continue to learn more. And I think what's been useful to see is that, finally, sort of occupational health and safety has been given a lot more attention than it's previously received. I think just some of the challenges or questions that I had, one was just, do the regulations that are available apply to government workplaces? So the police station or the Department of Environmental Affairs, because there are cases that occur there. And what if it's a Department of Labour office, and they, of course, do some of this investigation themselves? So do the regulations apply to them? A second issue is just on with respect to cleaning, and again, I think you've tried to address that. There's a lot of confusion about what sort of cleaning is necessary. A lot of retail stores just simply close and fog the whole place up and then reopen, which is quite a time-consuming, tedious process, and one wonders whether it's necessary and actually feasible, particularly when we are in a peak period like we are now. So those are just two initial questions. Sorry, there's one. I've just remembered the third question. The CDC in the US are downplaying, or they don't regard transmission from surfaces as being of as much significance. So I just wondered about that, because it's a question of, if I cough on a surface now and you touch it within the next 5 minutes, is different from if I coughed on a surface now and you touched it tomorrow. And how does one actually take that into account? I don't know what was the basis of their, proposals around the relevance of transmission via surfaces. They seem to be suggesting that it's not as significant, and what are the implications for cleaning and the need to do that, and the role of surfaces in transmission. So I just wanted your opinion about that. Thanks.
Thanks, Hassan. So I'm going to share that the slide from the study that I had earlier, which is the one that, so this is addressing the last question you had regarding the surfaces and the cleaning of surfaces. So what you can see in this study is the survival of the virus on surfaces for a number of days, and then doing a viral culture and looking at the viral titer when you try and culture this again. What the authors have made very, very clear in this publication is that actually the way that they are culturing the virus and then collecting it from the surfaces again is not typical of the way that we would see transmission. In other words, where you would touch it with your hand and then get infected by touching your face, etc. So they make it clear that although you can culture a virus in ideal lab conditions, we don't see the same sort of risk of, let's say, a banknote of 2 days and stainless steel of 4 days. We don't see in practice the same risk when you look at contracting the virus by lifting it from the surface with your hand and then bringing it to your face. So that's what the CDC is essentially referring to, is the lab versus, so in vitro versus in vivo type of studies that one would refer to, and I think that is difficult then to say, how can I then get infected from picking up the virus? In practice, it doesn't seem like it is as high a risk as we have previously thought from the lab studies. So I hope that answers the question, but obviously there's no studies to say, okay, then what is the rate? I don't think it's something that we can quantify, but in principle, we know within IPC that a healthcare worker hands is the way in which most diseases spread in the hospital, and hand hygiene has always been the most important component. And therefore we still apply the principle of making sure that surfaces are cleaned, environmental cleaning is performed, and hygiene is practiced. So I don't think that the lack of evidence in this case is evidence of a lack of transmission. We know that it is there. It's not as large as we initially thought. It's not 100% transmission, but I think it's still we know that hand hygiene is an important component. Then I think in terms of your other comment in terms of cleaning and then closing the workplaces. Again, I think that same slide, and there are obviously many other publications, and we know the coronavirus being an envelope virus is very, very fragile. In other words, it's very easy to kill, and disinfection is very easy, and therefore we are not concerned in terms of workplaces not closing down. If you have a contaminated workspace and you've disinfected it, you can use that workplace again within minutes after disinfection. The virus would be dead, and the workplace can reopen. So as I said, the closing of the workplaces would typically be the non-healthcare environments, and they are closed down because they don't typically do disinfection. They not just do normal cleaning with soap and water. I think in terms of COVID, this has changed. There are, in fact, many workplaces that do disinfection with hypochlorite solution, or just normal bleach or something. And if they do that, then in my opinion, they can open that workplace again immediately, and the staff can come back to work if they are not infected and they don't have symptoms. So in my view, that would be the way to deal with it. And then your other question of whether the Compensation Act and the Occupational Health and Safety Act applies, I will just very briefly refer to my screen again, if I can get there quickly. Legislation, Occupational Health and Safety Act. Let me just share my screen there again. So if one goes to the Occupational Health and Safety Act, so you will see then I'm trying to see, I think it's in the definition of an employer, if I can find it quickly. So employer subject to the provision of subsection 2, any person who employs or provides work for any person and remunerates that person expressly or tacitly undertakes to remunerate him, but excludes a labor broker in the point. So in all of these, it normally says that it includes everybody, including the state that employs a person. It's not specifically mentioned here, but we had a visit from the chief inspector, I think it was last week, or it might be the week before. I'm not catching up with all the days anymore. And in fact, the chief inspector's office was closed down because of ventilation systems that weren't in place. And therefore, the Occupational Health and Safety Act, the COIDA Act, it applies to all employers, including the state. The only people that are excluded are people for which other legislation provides the information. So, for instance, a mining area, etc., that is not covered by the Occupational Health and Safety Act and these regulations because it is covered by the Mine Health and Safety Act. When you look at a load line ship and a fishing boat and a sailing boat and so forth, that is covered by the Merchant Shipping Act and then the medical regulations under the Merchant Shipping Act. So those are the only people that do not fall under these acts because there are other acts that apply to them.
Thanks, Jack.
Thanks, Jack, for that extremely comprehensive answer. We have a couple of other questions, some of which, Jack, I think you are able to also see some of those questions. So I'll just reflect on Nicholas van der Water's question. Nicholas, you indicated that you did join later, and I think Jack did cover some of the the processes that they undertake at Tygerberg Hospital to engage in rigorous screening for healthcare workers. So Jack, if you want to add a comment on that, you're most welcome to, and we will be making the presentation available. So Nicholas, you could then refer to that. There's also a question around whether training is, I suppose the question is, how can training be booked for staff who are seconded to the IPC office, Jack? So maybe you can give a comment on that. And then Prof. Chictor asks, to what extent are the regulations applicable to the education sector, and what exemptions are considered for a deviation from what you presented? So I suppose that speaks to lessons learned and transferability of the experiences. So I'll stop there. Have you answered those questions, and then I'll tackle the next lot of questions. Thank you.
Okay, so in terms of Prof. Chictor's question regarding the education sector, so yes, they are also required to comply with these regulations. They are not exempt in any way. And I've been in contact with a number of schools, and I'm advising a number of schools, and specifically intimately involved in the school where my 4 children are attending, and we are implementing a very similar system there. Obviously, a lot more difficult to manage things like social distancing, etc., especially in the preschool environment. But there is some evidence that the risk for severe illness is much less, and also it seems like transmission is not as prevalent in young children as it is in adults, for instance. However, what we've done with all the schools that I'm advising is the vulnerability assessment becomes crucial. Although you are implementing all these systems in the workplace setting, and one can then limit transmission in the workplace as much as possible, there is a risk during break times and so forth in the school setting that transmission can take place. And then we know that all of these measures, and I mean, everybody in this conference call can attest to this, that we are not wearing our masks at home, and we're not practicing social distancing at home unless there is a specific case, but by that time it might be too late. And therefore we've gone out of our way to do these individual risk assessments for every child in the school. And there are some children that have got immunosuppressive disorders, or they're on medication that makes them vulnerable. But we actually found that there's a significant number of children that have got vulnerable people at home. And should that child then contract the virus in the school environment, they would then expose the elderly and the sickly people that are not typical in a workplace setting. I think the same principle will obviously apply to all workplaces, but this is something that we worked on quite extensively, and the problem is, of course, during the peak. So if healthcare is available and we've got the capacity again after we've been to the other side of the peak, we can relax some of these restrictions. But we've gone out of our way to make sure that people are protected during this time when they might need healthcare, but it might not be available. So I hope that that answers the question of Prof. Chictor. Then I see Nick says, considering the hospital setup has been shown to be a locus of transmission, should we not be performing a more rigorous screening process on healthcare workers than the general public? And the short answer is yes. So what we would notice is that even in the national guidelines that we've set for testing, is that we are prioritizing testing, and obviously because of the restrictions we have on test capacity. But what you will notice is that healthcare workers are included there as as some of the priorities that we test for this very reason. But again, we are not advising at this stage to do random screening, let's say once a week or once a month at this stage. We are still just screening people that are symptomatic, and then day 8 if they've had a high risk exposure. But then if there is an outbreak situation, then one might want to do some more testing in that specific setting. But that would be guided by a specific investigation that was performed.
Thanks, Jack. We also have a question from Portia Hendricks around training and booking of training, if you can point us in the right direction.
So in terms of training, we obviously developed our own resources that were custom to our hospital setting and what we are doing and how things should flow. For instance, how to refer people to the occupational health clinic and so forth. But at the national and provincial level, there are resources available, including video material and training material that has been developed. And those are available on a number of websites. So the NICD website has got a number of training things, Department of Health, and then also our own Department of Health provincially has got training resources and material available that could be used for the training, including some videos that one can use.
Thanks, Jack. And I think what we can commit to is sharing some of the links to the training sites and the materials that you referred to as part of the mailing list for this particular talk. There's some additional questions. If you can also refer to that, Jack, it's from Randall Ortal, who asks, can the occupational health registered nurse complete the WCA documents for the staff? And should HR capture the 14 days isolation after positive corona test as special leave or sick leave? Just some clarification if you are able to address those questions. Then Beth asks a question just below that in terms of what is the authority of the Department of Labour and Healthcare Settings, and thank you to the guest who was assisted to answer that question, and Jack, if you are able to assist with that as well, that would be great. Thank you.
So in terms of the documentation and whether an occupational health nurse can complete it, when the main one that needs to be completed by a medical practitioner is obviously the first medical report in terms of an occupational disease, as I've shown here. So you can clearly see here that there's a signature required by a medical practitioner. So I don't think that a occupational health nurse would be able to sign this. But again, it's not an occupational medicine practitioner that needs to sign it. It can be any medical practitioner. All the other documents, the employer's report, etc., that can be completed by any other person, including HR people and so forth. But the WCL 22, the first medical report, is the problem. And the reason it's a problem is because the people go to a testing center, they're not necessarily seen by a medical practitioner even. The test can be performed by any healthcare worker working in that setting. And then it goes to a lab, and the person is then phoned by a dedicated team that phones out the results. And such a person can get a diagnosis of an occupational disease without even seeing a medical practitioner at all. So our advice at a provincial level was that each employer and each facility should identify a medical practitioner that can sign this form. And it's really not a difficult form to complete. It's just the date of the examination, nature of the disease is obviously COVID, the cause of the substance is SARS-CoV-2, and then what is the things in the clinical examination, see the positive test. And then just is the employee unfit to work, etc. So it's a very easy form to complete. One might even have an admin person complete these and just get a doctor to sign these. I think this will still be acceptable. But this is essentially something that is not specific to COVID. It is the first medical report for any occupational disease. And that's just one of the problems that we are finding here. So I think that would be the question specifically is the WCL 22 and not the other documentations which anybody can complete. Then I think in terms of Dr. Engelbrecht's question about the jurisdiction of the Department of Labor over the Department of Health, and I think this is a very high level question that one is asking. So obviously the Department of Labor has got jurisdiction in terms of the Occupational Health and Safety Act, and that all employees are covered and all employees should work in a workplace that is healthy and that is safe, and that the inspectorate is there to ensure that this is happening. But in terms of the higher level questions and to the extent to which this can happen, I'm not sure whether that question has been asked in a truly legal manner and whether the state would be excluded. I know that this question has been asked before, specifically in terms of the Department of Defense, where I was working previously, and there was a specific comment made that the Department of Defense cannot work healthy and safely. They are there to put their lives in danger for the country, and in those legal battles that ensued, it was made clear that the Department of Labor do in fact have jurisdiction, and that if we are not at war, they should still be working healthy and safe. And only when the Defense Act comes into play when we are at war, then those restrictions might apply in those specific settings. So I do think that it is important. If one looks at the international literature, we know that that mining has got the highest risk for employees in terms of number of people dying, or the proportion of people dying. Second most, which is far exceeding things like the construction industry, etc., is health. So we kill more healthcare workers than people that are killed in the construction industry. And that is a major concern, and yeah. So my opinion would be that that Department of Labor does have some level of jurisdiction, at least, if not full.
Thanks, Jack. I've got one of the questions that was asked was about capturing of leave days. Should HR capture the 14 days isolation after a positive coronavirus test as special leave or sick leave? Are you able to assist with that?
Yeah, so that's a very, very difficult question to ask, because there's been so many circulars regarding this. And obviously one talks now in the context of Department of Health employees, because this will be different for each company. I mean, a company would have their own policies and HR policies and guidelines. So we've had some circulars that were issued by the Department of Labor, also from the Department of Health and the Department of Public Service Administration. Obviously, the people that have got jurisdiction in this regard would be the DPSA, and the guidance that they give for all state departments would apply in this setting. Unfortunately, the guidelines that they have given does not account for all situations. It does account for some of the important ones, but we've had some instances where this does not provide clarity in all cases, and therefore from our hospital side, via our CEO going up to Silver Command, etc., we've asked that this question be clarified by the DPSA, so that they can give very clear guidelines on how this should be managed. In some cases, it is very, very clear. So in other words, if a person has got a diagnosed disease and the person is ill, then it's clear that it is sick leave that applies. And we've got the whole pillar system and so forth. But the question comes in when a person needs to be isolated or quarantined based on medical advice, but then the person tests negative and so forth. So all of these are different scenarios where specific guidelines are required. and there's tremendous potential for abuse of the system if you are using just special leave in all cases. So I haven't had any specific feedback yet, and I'm hesitant to speak on the type of leave. From an occupational medicine point of view, I know when I need to complete a sick note for an employee when they are too ill to work, and I would leave this decision and this proclamation to the HR people who needs to provide that guidelines. I'm not sure whether somebody else on the group, perhaps Dr. Engelbrecht or somebody else, might have more information on this, but I don't have any more at this stage.
Okay, thanks, Jack. If anyone does have more information, please feel free to raise your hands. Just a note, we're nearing the end of the webinar. Just some of you may not be aware that your cameras are on, so please feel free to switch them off if you don't mean to have them on. There's one more question, Jack, that you may or may not be able to answer. It's, is there a place for antibody testing to identify staff that have been exposed and safe?
Yeah, so the jury is still out on this one. Sorry, there's someone. Okay, so there are a number of studies talking about the antibody responses for COVID, and the question then, of course, is if you've had your COVID, are you then immune? And would you be able to get COVID again? The second question is then also whether you are able to infect others, even though you can't get the disease. Can you still carry the virus and therefore transmit the virus? I don't think that we've got the full answer. It seems like there is some level of protection after you've had the disease, and if your IgG levels are up, of course, but how long these last, etc. I don't have any updated information on this. There are a few cases described where people got reinfected, but I'm not sure about the way that these things are tested, because it's important to distinguish between the different tests. Obviously, the test that we currently use test for viral RNA, and viral RNA and the presence of that does not necessarily mean that you can infect a person. Even dead virus would test positive. We've seen that a lot. For instance, their studies reported that they were able to positively identify viral RNA in ventilation systems in the hospital, and then they asked the question whether the virus could be spread via the airborne route. And the answer is obviously no. This virus does not spread via the airborne route, and detecting viral RNA doesn't show that it spreads via this route. It's just dead virus that is detected there. So sorry, I don't have any more information on that. We're keeping our eye on the publications, but nothing solid at this stage where I would say a person is definitely immune and can go back. We know that there's some level of safety, though.
So thanks very much, Jack, and also thanks, Dr. Engelbrecht, for your answer, where you note that you agree that the HR practitioners will apply available circulars as per the setting. And then she asked a question in terms of how strong is the evidence that quarantine of 10 days would suffice. Is that something you'd like to answer, Jack?
Yeah, so I'm actually actively involved in looking at this question at the moment. And there's a group within the province looking at this, and then nationally the NICD has looked at this as well. So at the moment, it seems like the majority of people, if they contract the virus, would remain infective and be able to infect others to around day 8. And that's if you now use viral cultures and see whether you can culture virus from that person. So the question is whether the 14 days is not excessive and that people might be able to go back to work earlier, again, without doing any tests. So there is a proposal at the moment that we look at 10 days and that would that would in fact suffice for most cases. I do think it's important to note that there's a single case study, so only one case that I'm aware of that was published where there was transmission and then a subsequent a positive viral culture done on a person 18 days after the diagnosis of the disease. But I'm not sure what to make of that as an outlier. At the moment, our recommendation is 14 days, and that you can return back to work and you don't need any other testing. I think for the majority of people, 10 days would suffice, but our recommendation would probably still then include that a person would need to continue wearing a surgical mask, say to day 21 or something. Then the person would be able to go back to work. Of course, we are talking about the mild cases here, and if a person has a severe disease, then we don't look at the day 10 post-diagnosis. We then look at day 10 after you've been discharged from hospital and you don't need to use the oxygen anymore, so the requirement for oxygen is stopped. And therefore, this would not apply to people who are still symptomatic, people who are very ill, people who are admitted to hospital. We're now referring to the general person who's got mild disease or asymptomatic disease with a positive test. I think most of them would be able to go back after 10 days.
Thanks very much, Jack. And I see, Puni, you've added a question. I think your question's been answered now. So we've drawn to the close of this really interesting and important webinar. And Jack, I hope that we can have you back within a few weeks' time to give us an update. And I know there's a lot more to talk about. I particularly would like to also hear more about what actually happens within the clinics and your engagements with the staff that you see and lessons learned. So I have a question that I'd like you to answer as we close, but I see there's just one more question from Sukari. What happens when a patient has COVID pneumonia? Okay, I think you've also answered that question. So as we close, what for you are the lessons learned for the future of occupational health, occupational medicine, within healthcare settings and other settings? And what does that mean for teaching and learning and capacity building?
So I think what happens with COVID in general is that it has applied additional pressure on the system, including the healthcare system, and it simply just exposed some of the shortcomings that we've had across the board, and that applies to occupational health as well, all the others obviously as well, but it has shown the importance of occupational health and the occupational health system, and that our approach to hazards in the workplace in general is solid, you know. So the approach in terms of identifying the hazard and then prioritizing the control measures, doing medical surveillance on staff members. I think that whole system is something that from implementing this for COVID, we can use it going forward and making sure that the system is used for others as well. COVID is just showing up in a very short time span, but we've got other epidemics currently, even in our healthcare setting. We think, for instance, of tuberculosis and the number of staff members that are dying because of tuberculosis every year. You know, so it's just because this happens in a very short time period, but we need to have the same systems in place for all the other occupational diseases, other occupational injuries. We all know that it's very difficult to find a nurse in the healthcare setting that is not suffering from a back problem. So there are many other occupational injuries, occupational diseases that needs to be addressed, and I think that to me is the lesson. The others is just the details of this specific disease, but the overall system, I think is something that I found very satisfying to implement and working in this environment.
So thank you very much, Jack. Once again, I think to summarize, COVID-19 has created further impetus and has also provided some kind of framework for strengthening occupational health and safety and medicine in the future to come. And so we look forward to inviting you back within a few weeks' time to hear a little bit more about developments and focus on some other important aspects of occupational health and safety aspects of COVID-19 within the workplace. Thank you very much for those who've asked questions, and the presentation and the webinar recording should be available on our website. You can contact Stacey Blows as per the advert if you require any information. Thank you and have a wonderful day.
Thank you.
Thanks.
Thanks, everyone.